Today, I am reaching out to all of you who are postgraduates, whether you are doing MD, DNB, DTCD, or even DM in pulmonary medicine. We have taken an initiative under the auspice of Indian Chess Society and with the help of our educational partner, Glenmark, to start PG teaching program, which is like a uniform method of teaching. And we will be taking the best teachers across India to take different topics on third Sunday of every month. This Sunday, we are starting with symptomatology in the respiratory medicine. And two symptoms which are going to be covered are cough and dyspnea. Every program will have a mentor who's a senior professor and head of the department of PG teaching institutes who have been teaching for years together. You'll be happy to know that your mentor today is going to be Professor S.K. Jindal. He needs no introduction. We all know him. He has hundreds of thousands of people who have been taught by him, and he's a mentor for all of us. And we are also have devised a unique way of teaching where various other specialities which are required, like anatomy, physiology, biochemistry, microbiology, pharmacology, and other super specialities like cardiology, neurology, endocrinology, whenever they are required in the topic, they will be along with us and along with the pulmonologist, lead clinical discussant, who's going to discuss it. So today, when this program sets going, we are going to discuss about the respiratory symptoms. And you can see that there is going to be a pre-test questionnaire. With this pre-test questionnaire, where there will be 20 questions, multiple choice, you will be able to assess yourself that how many are correct and how many are wrong. And then very importantly, throughout the teaching of these 2 hours, it will be an effort to improve your knowledge on those areas which are weak. And then finally, a post-test questionnaire, which will obviously be taken at the end of it. And once we see that there is a significant improvement, it is like you yourself who can assess that how well the program is going and you are grasping it. But in case you are not able to get on that particular day when the program is live, they will be all archived. So they will be in a fashion where you can go to that site, which we will be revealing to you in a little while. And then you can take the whole module, take the self-test questionnaires pre the lectures, and then after lectures do it again and submit it to us. So if we find that in the pre-test questionnaires, you are really doing very good and you have learned much more and almost reached 20 out of 20 at the end of the questionnaires, there will be a surprise gift coming to all of you from my side. It's nothing to do with any other platform. It is going to come from me. So please email your answers, pre-test as well as post-test, to us and let us evaluate that who has done the best, and perhaps we'll choose 10 best postgraduates of the year and see to it they're suitably rewarded for that. This is teaching program. It is purely for the postgraduates. But if you are a young clinician, or if you are a pulmonologist like me, who's never shies away from learning at any point of time, you are happy to join it. You can still go through the same program by registering for it. So watch this episode, and then every episode which is going to be on air on Sundays, which is the third Sunday, 11 a.m. to 1 p.m. And we will be going through a module for the postgraduate teaching in respiratory medicine, which is under the Indian College of Respiratory Medicine, a new initiative under Indian Chess Society, and of course supported by Glenmark.
Good morning. I'm pleased to welcome all of you to this very important session on virtual mode, you see, for the on kind of discussing approach to different cases, symptomatic approach to different respiratory and other kind of diseases, you see. I am thankful to Dr. Deepak Talwar as well as Professor Richa Gupta, who is organizing this session, for giving me this opportunity to participate. I think this is a very important activity, especially for the postgraduates. I'm sure they would learn a lot from this activity. Today we have two cases which will kind of discuss the approach to a case of breathlessness, and the second one is approach to a case with chronic cough. So I'm sure that you will enjoy it, and you will have, of course, different questions to which will have your answers before and after the session. So thank you very much, and now we can proceed ahead with the first case. You see. Who is going to present the case? Is it ready? Okay.
Very good morning, sir. I am Dr. Akshay, DNB first year resident from Metro Center for Respiratory Diseases. My first case, Mr. Javed Akram, a 52-year-old Muslim male, never smoker, a diving technician by occupation, belonging to middle class economic status, with no known comorbidities, no history of exposures, presented to MCRD OPD with complaints of shortness of breath on and off since last 2 years, an increase in snoring in the night since last 5 to 6 months. History of presenting illness. The patient was relatively asymptomatic 2 years back when he gradually developed shortness of breath on and off since last 2 years, which was gradual in onset, grade 1 MMRC initially, progressed to grade 2 MMRC, which was progressive in nature, more in night, more during winter, and more in supine position. On general physical examination, he was conscious, cooperative, oriented to time, place, and person. He was well-built, well-nourished, BMI of 30, with no icterus, cyanosis, clubbing, lymphadenopathy, or pallor. JVP was not elevated, sir. He presented with 96% on room air. Examination of the respiratory system. On inspection, the respiratory rate was 25 per minute, which was regular, abdominal thoracic. Trachea was central, apex beat not visible, chest movement equally bilateral, chest wall bilateral symmetrical. There was no droop or kyphoscoliosis, no visible sinuses, pulsation, dilated veins, or scars. The skin over chest wall was normal. On palpation, there was no local rise in temperature or tenderness over the chest. Trachea was central. Apex beat was not palpable. Chest movement equal bilaterally. Chest expansion was 4 centimeters with a differential expansion of 2 centimeters on the left and 2 centimeters on the right side. On percussion, bilateral resonant percussion note was noted on the anterior, posterior, lateral chest wall. On auscultation, breath sounds present bilaterally and equal in all regions of the chest. This was his X-ray, sir. Basic lab investigations were done, sir, in which the hemoglobin was normal. Counts were not raised. It was 8,200. KFTs were normal. 2D echo was done to rule out any cardiac issue, which was normal 50 to 55% with no PAH. LFTs were normal, sir. And IgAC were in normal range. His BNP was also normal. That was less than 20. Further management, sir, lung functions and 6-minute walk test was done. It shows preserved lung volumes and normal spirometry, sir. The 6-minute walk test His baseline SpO2 was 97 to minimum of 95, which was normal, sir. He covered 507 meters, sir. Thank you, sir.
Okay, thank you very much for a interesting presentation. I'm sure the case is well kind of understood by everyone who is participating. Generally, I think the approach to dyspnea, that's what we have to discuss it. But before that, I think is the physiology to be discussed before that, or?
Yeah,
Please.
I've been asked to discuss the pathophysiology of dyspnea. I am a professor of physiology at CMC Bangalore. Can I share my screen?
Yeah, please go ahead. Yeah.
Progression takes a while. Let me see if the slides are moving. Yeah. Dyspnea is a very familiar term to all of us, and I think my job here is to place, to recap what you all know already. I understand that there are at least 3 distinct sensations which are reported by patients: an increased effort of breathing, chest tightness, and air hunger. Now, dyspnea being a sensory phenomenon, it is generated at the sensory cortex. There are a number of causes of dyspnea, and what I'm going to do is pick some of them and see what combination of inputs into the sensory cortex generates this sensation. Prior to that, we'll look at respiratory rhythm generation over a minute or two, just to understand what we mean by the respiratory center and its command. Now, the respiratory center sends out efferents to respiratory muscles, and the center consists of the pre-Bodzinger complex, the ventral respiratory group of neurons here, and the dorsal respiratory group dorsally and a little more centrally, the pneumotaxic center and apneustic center in the pons. Then there are motor neurons in the spinal cord which send efferents to muscles. The pre-Bodzinger complex is the rhythm generator. Impulses originate from there and turn on the neurons in the dorsal respiratory group, which directly or indirectly supply the respiratory muscles. The pneumotaxic center is the off signal, which turns off the DRG neurons, and so that expiration follows automatically. The apneustic center supports the on mechanism. Now, all of this is subject to feedback from the chemoreceptors, peripheral chemoreceptors, which sense hypoxia, and central chemoreceptors. They are located ventrally in the medulla. So the chemoreceptors send their output to nucleus tractus solitarius, which is the sensory nucleus of the vagus situated close to the dorsal respiratory group. And there's also pulmonary efferents. There are at least 3 classes of pulmonary efferents, and I'm showing one of them here, the stretch efferents from the lungs, which are responsible for what we call the Herring-Broyer's reflex, which is the second off signal to the rhythm generator, or to the dorsal respiratory group, the first of them being the pneumotaxic center. Now, given this, let us look at what afferents can create these different types of sensations, or what combination of afferents can create these sensations. I don't know how to move that. Okay. Now, the medullary respiratory center, what we just saw, sends out the motor command to respiratory muscles. That is modulated by inputs from the chemoreceptors. We're now going to see how the sense of an increased effort can be generated. Now, this type of dyspnea, if we may call it, all of us know about it because that's what we have when we do submaximal exercise. Now, that can generate entirely due to a copy of the motor command being sent to the sensory cortex from the medullary respiratory center, what's called the corollary discharge from the medullary respiratory center. That alone can explain the sense of increased effort that is required. In addition, the sensory cortex also gets feedback from the respiratory muscles, the muscle spindles and Golgi tendon organs in the diaphragm and the intercostal muscles. Proprioceptors from these muscles send impulses to the sensory cortex, which can compare the afferent impulses with the efferent, the copy of the efferent that went to the muscles. It also compares information from lung and airway receptors. There are 3 kinds of them. Let me first refer to the first one, which is the pulmonary stretch receptors, which inform changes in lung volume to the sensory cortex. We just saw them already as being responsible for the Herring-Brewer reflexes, which turns off inspiration. They send impulses to the sensory cortex as well. Now, the cortex is able to compare the motor command with feedback from the respiratory muscles and from the lungs. If there is a mismatch between the efferent and the afferent, then there can be a heightening of the sense of breathlessness or an increase in dyspnea, what's called efferent-afferent mismatch or neuromechanical dissociation. In ventilated patients, a mismatch between the patient's respiratory drive, which is essentially this, which is fed to the sensory cortex. Even if his muscles are paralyzed, the motor command originates and the sensory cortex will be aware of the motor command. A mismatch between that command and the ventilator settings can induce a sense of dyspnea. An interesting clinical application is that vibratory stimulus to the chest muscles can relieve dyspnea. Probably it tells the sensory cortex that the respiratory muscles are working. And what's more interesting is that such vibratory stimulus has to be given during inspiration. And if it happens during expiration, it only worsens the dyspnea. Now let's look at this quality called air hunger, or a sense of suffocation, or a sense of not enough air. And that, I believe, is generally reported in COPD. A combination of many sensory inputs can create dyspnea in COPD. One of them is fatigue or hyperinflation of the respiratory muscles. When they are hyperinflated as an emphysema and the range of movement is less, the proprioceptive input is going to be less than the motor command. That's one reason for dyspnea in COPD. Then let's consider the chemoreceptor input. Is hypercapnia a probable initiator of dyspnea? It's possible because the central chemoreceptor command goes to the sensory cortex. What we must be aware is that in chronic COPD, even if there is hypercapnia, there need not necessarily be dyspnea. And that's probably because it's not the high carbon dioxide that is the stimulus for the central chemoreceptors, but the local pH change because of that hypercapnia. And in chronic COPD, because of secondary metabolic alkalosis, the pH may have been set right. And hypercapnia, therefore, in chronic COPD may not be initiating dyspnea. But in an acute on chronic case, a sudden change in carbon dioxide can induce dyspnea. Does hypoxia cause dyspnea? There is some evidence that hypoxia may cause dyspnea because oxygen therapy in COPD may relieve dyspnea. And exercise-induced dyspnea is more if subjects breathe a hypoxic mixture in experimental studies. So is there a possibility of hypoxia being a stimulus for dyspnea? In spite of these evidences, it appears that hypoxia has a very limited role in the pathogenesis of dyspnea. If at all anything, it could be an added factor for dyspnea in COPD. We've heard about happy hypoxia during the pandemic. So hypoxia per se need not induce dyspnea. Summarizing, the probable causes of dyspnea that one has to consider in COPD are fatigue or hyperinflation of muscles, hypoxia, hypercapnia. In addition, there's a very important phenomenon called dynamic airway obstruction, which all of us know about, that is happening in normal people during forced expiration, and that is responsible for the residual volume. Dynamic airway obstruction can happen early during expiration in COPD. So this is a narrowing of the smooth muscles of smaller bronchi during forced expiration. And that can induce a sense of dyspnea, and that seems to be the important cause of dyspnea in chronic states, stable states of COPD. And dynamic airway obstruction must be sensed by receptors in the airways, which belong to the same class of pulmonary stretch receptors, but these are mechanoreceptors in the airways and not in the lung parenchyma per se. And they convey early dynamic airway obstruction in COPD to the sensory cortex. So these are the 4 probable inputs to the sensory cortex in COPD. I'll rush through. And this is exactly why breathing through pursed lips helps, because if you maintain a higher pressure in the airways by breathing through pursed lips, you could relieve dynamic airway obstruction to a considerable degree, and that can give relief in dyspnea. And this is something that respiratory therapists teach patients about. Asthma, obviously, there's bronchoconstriction. And in addition to the mechanoreceptors in the airways, there are also irritant receptors which can sense histamine and convey that information to sensory cortex. And commonly, what is referred to as chest tightness is the quality of dyspnea in asthma. Now, none of these inputs from either the proprioceptors from muscles or the motor command or the chemoreceptor input, pulmonary stretch receptor input, none of these can explain dyspnea and pulmonary edema, and we have to invoke a special class of receptors, the C fibers, which are unmyelinated nerve endings, sitting close to capillaries, between capillaries and the alveoli. And that's why we call them juxtacapillary receptors, and therefore the J receptors, which are responsible for the J reflex, studied quite a bit by Professor Paintel, professor of physiology. Now, C fiber input can be an important source of dyspnea. In pulmonary embolism, we have to think of receptors in the blood vessels per se, generating a sense of breathlessness. So it would be a good exercise for you to list the probable cause of dyspnea and the diseases and see which combinations can give rise to dyspnea in that particular state. In neuromuscular disease, say in myasthenia gravis, for example, it's an enhanced sense of effort and an afferent mismatch. In COPD, we just saw it could be fatigue of respiratory muscles, hypercapnia, not so much hypoxia, but it's an added factor, and dynamic airway obstruction, stimulating airway receptors being a cause for the dyspnea. And in asthma, we saw that there could be an increased sense of effort and bronchoconstriction, C fiber input in pulmonary edema, pulmonary vascular receptors in pulmonary embolism, and an afferent mismatch in mechanical ventilation. So that's the summary. I'd like to end with, so we can have all these inputs to the sensory cortex responsible for dyspnea. A special mention must be made about upper airway and face receptors, trigeminal input to the sensory cortex, which can actually relieve dyspnea. So blowing cold air on the face is known to relieve dyspnea, probably because it gives a false sense that there is increased airflow in the airways. For your own understanding, you might want to read about the alpha stat theory, the effect of temperature on dyspnea, and what's called the metaboreflex, metabolic receptors in tissues, especially muscles, giving feedback to the sensory cortex. Thank you.
Okay, Thank you, Dr. Subramani. I think that was a very elegant and elaborate explanation or description of mechanisms of dyspnea, which many of clinicians in particular forget. You see, I think what interesting was that in different respiratory diseases, mechanisms may be different, you see, and are different, in fact. And I think our table was very nicely shown that mechanism. I'm sure that would be useful for the participants. I think
Thank
that.
you, sir.
Thank you. The second part, of course, is the actual going to clinical case discussion, which I'll be just sharing, I think. Can you see my slides now?
Yes, sir. Please.
Okay, whenever we see a case of dyspnea, what is the general approach, you see? Or what is actual dyspnea, as has been explained, that it is a difficult or labored or unpleasant breathing, and that is distressing. It is most of the time what we realize, it is a feeling or a kind of sensation, you see. That is what is most important, because there may be people who are actually breathless but may not feel dyspneic apparently, you see. Often, of course, we identify them simultaneously or similarly, that it is shortness of breath, and frequently described vaguely, not a single sensation. But there can be different type of respiratory discomfort, as has been explained by Dr. Sudharamani, that air hunger or work and effort-related discomfort, chest tightness or congestion. And that's how patients come to, because many times you see the patient will complain of chest tightness or heaviness, or sometimes even chest pain and so on, you see, rather than saying as breathlessness. The actual approach consists of the standard clinical examination, the most important being the history and physical examination. I must stress here that in respiratory medicine in particular, and in general in medical case examination, the history is far more important than physical examination. In fact, in today's world, the physical examination has been left with the kind of limited kind of options, you see, or limited value in a routine setting, because we have a lot of investigations and other things which may go far or against the examination, but still examination remains important. For dyspnea, of course, the most important is the clinical setting, whether it is emergency or ambulatory, because both these situations, the cause of dyspnea may differ, you see, and that's what a clinician has to understand. The acuity of onset is very important, whether it is acute or chronic, and the other factors include the age of the patient, severity of dyspnea, associated symptoms. So whenever we make a final diagnosis, we have to keep all these things in mind, you see, and then we go for standard investigations, chest radiology, and of course the others, which vary depending on the cause of dyspnea. Now, coming to this case, I think if we examine on the same parameters which I have just discussed, what is the background of this patient? He is a 52-year-old Muslim male who has never been a smoker. These are the two important factors which we realize, or which we have come to know from this history, that is middle-aged, 52-year, and he's a never smoker. I think that is what is important here. And then there is no known comorbidity. There is no history of exposure. I think that also is an important history, because in respiratory medicine, especially for causes of breathlessness, exposures are important. And then we come to the chronicity or acuteness of the symptoms, you see. These are present for 2 years. which means it's not an acute history, it's a chronic history, and that is an important factor to know. Increase in snoring for 5 to 6 months. It is another important symptom which we need to analyze in this patient. So he was relatively asymptomatic 2 years back and gradually developed shortness of breath, which was grade 1 MMRC initially, on and off 2 years. So which means on general terms, it was relatively milder dyspnea, you see, but it was more at night, more during winter months, and more in the supine position. All these factors are important to some extent, you see. I'm sure you all know what is modified Medical Research Council dyspnea scale, which is used to assess the degree of baseline functional disability due to dyspnea, you see. So it is useful in characterizing the baseline dyspnea in patients with respiratory diseases, particularly the COPD, but now the scale has been used for many other diseases as well. Grade 0 being strenuous exercise, and grade 1, which this patient had, was hurrying on the ground level or walking uphill, you see. So as we go from 0 to 4, the severity of dyspnea increases. So that's what we have come to know, that it is a middle-aged man who is complaining of breathlessness of milder kind, you see, for last 2 years and associated with snoring. General physical examination is essentially normal. This is an important finding. BMI is 30, I think. That I have you see, highlighted because it is an important cause of breathlessness. Other parameters like pulse, blood pressure, respiratory rate are generally normal, you see. The general examination of respiratory system as well as cardiovascular system, the abdomen, and neurological examination were normal, you see. Now again, this I think I'm sure all of you know that body mass index is defined as the person's weight in kilograms divided by the square of his height in meters. So that is a good index to tell about the kind of body weight, you see, rather than, because that depends largely on height as well. So according to Indian standards, if BMI is 30 and above, it is classified as obesity, I think. So it is an obese individual. That is the other important finding which we have come to know. Investigations of the hemogram, LFT, chest X-ray, echo are normal. There is no pulmonary arterial hypertension, and pulmonary function test is normal, you see. So all these normal findings also have their own value, because they, to a great extent, will exclude certain diseases, you see, which are otherwise, for example, X-ray is normal. So we know that many of the diseases or as cause of breathlessness are unlikely, including pulmonary fibrosis or COPD, and of course the other causes, infections and pneumonias, although they are more important in acute causes, you see. We also know we should keep in mind that X-ray can be normal in all these diseases as well in early phases. For example, COPD, ILD, X-ray can be normal. His 6-minute walk test, which is used to it is a submaximal exercise test to assess the aerobic capacity and endurance. And it was 507 meters with baseline saturation of 97 and minimum of 95. Practically, it's again normal, although the normal value for 6-minute walk test is highly variable and it will depend on patient to patient. So what are the general causes of dyspnea? Because that's what we have to find out in this patient. Cardiac and respiratory, these are the two most important conditions, but otherwise others can be like deconditioning, endocrinal causes, gastrointestinal. I have listed most of them, just for the purpose of completion of the list. Many of these may not be necessarily important, especially in this patient. Cardiac, of course, we have practically excluded here. There is no kind of long history of cardiac disease. Cardiomegaly is not there on chest X-ray, and the echocardiogram is also normal, you see. Then, for example, the neuromuscular diseases are also excluded from history. Upper airway obstruction is practically excluded. We are also not told of any kind of endocrinal cause. He is obese. There is no doubt about it, you see, according to the body mass index. Other causes like psychiatric causes, anxiety, depression, hyperventilation syndrome, they are generally considered, but towards the end, after exclusion of important causes, you see. Renal disease is not there. There's no evidence of renal failure. Blood biochemistry was normal, etc. So I think, by and large, most of these causes, except few, are excluded, you see. Pulmonary causes of breathlessness are more important, especially for the chest physicians. Asthma, COPD. There is no history suggestive of asthma. No history of COPD. He gets very mild breathlessness and only at night. He's a non-smoker as well. There is no previous history of cystic fibrosis, bronchiectasis, interstitial inflammation, or kind of compressive airway. So most of these causes are excluded. Rheumatological causes like vasculitis and many of these things, there is no history and no real evidence, but sometimes any disease can mimic other things, but certainly there is no evidence. Vascular pulmonary thromboembolism, pulmonary hypertension, etc., are also not there on investigations or on echocardiographies. So then what are the other important tests which are important in evaluation? Pulmonary function tests or spirometry is very important. It's normal here. Methacholine challenge is done in a kind of a normal spirometry in a patient suspected strongly of asthma. It was not done because it is not done and it was not perhaps required. Some of these tests are done only when really indicated, you see. Imaging, of course, chest X-ray is normal. We don't have CT scan because there was no real indication to do that, you see. Some other investigations like the blood natriuretic peptide or D-dimer, etc., they are done only in specific conditions. So many of these things are done in overall evaluation, and I have listed here, but obviously they are not done in every case, you see. If it is acute dyspnea, of course, that is a priority for any physician who sees such a patient, because that's maybe life-threatening, like from pulmonary embolism, acute myocardial ischemia, or infarction. Most of the time, these are cardiac causes which are coming for the first time as emergency causes of breathlessness, or it could be other respiratory causes like acute pneumothorax, upper airway obstruction, etc. You see, or of acute exacerbations of a known case of asthma or COPD. So these are not really relevant here in this patient, you see. So chronic dyspnea, I have already said it. So that objective test in this patient, chest radiograph is normal, spirometry is normal, and the other tests were not done, you see. Sometimes, of course, you kind of use therapy also as the one of the important tests for diagnosis, like bronchodilator inhalation and so on. Of course, there are specific terms like positional, nocturnal dyspnea, trypopnea, when dyspnea develops, etc. So I've just again not really. So what is really the cause in this patient? You see, the only important finding which are from history and physical examination as well as investigations being that he is a never smoker. He's a obese individual. He snores a lot, and his breathlessness increases at night, in winters, and when lying straight. You see, other all examinations and investigations are normal. So I think if we really come to a diagnosis, then it would be what I have listed in the general causes as deconditioning, obesity, or even sleep apnea syndrome. You see. Now, these are some important causes of breathlessness, which are forgotten on routine listing or routine differential diagnosis. You see. But they are important if other important causes like asthma, COPD, interstitial lung disease, cardiac causes are excluded, you see. One sees many such patients in the OPDs in whom the diagnosis frequently, who keep on complaining breathlessness, but otherwise everything is normal. And what we call as, it could be either deconditioning, and sleep apnea syndrome, I said, is one of the causes of dyspnea, although it is also an important cause of snoring, etc., as has been discussed. So I think I'm not labeling it necessarily as sleep apnea syndrome, because I do not have the final testing for sleep apnea syndrome. But certainly obesity and deconditioning, of course, you understand, is important in all such obese people who are relatively kind of do not do exercise daily and relatively immobile, etc. So I think finally I will list this cause as or this case as possible sleep apnea syndrome, and sleep study, full sleep study, or polysomnography should be done, which should establish the diagnosis. Thank you very much. So can we go to the questionnaire, the questions now?
Saurabh, we can take up the poll.
Yes. Is it for both the cases together?
Yeah,
or
put together, sir. It is put together.
Put together. So all right, then we can go to the second case. I think presentation of second case of chronic cough. Isn't it, Dr. Who is going to present that?
Sir, I am, sir. Thomas here.
Thank you. Thank you. Sorry. Please go ahead, you say.
Yes, sir. Good morning to all. The second session for today in the symptoms for respiratory medicine is dry cough. So I am presenting here a 45-year-old lady who is a homemaker who presented with dry cough for the past 2 years. Cough has been persistent and is present during day as well as the night. There was no postural variations and she could not identify any definite triggers. But she gave history of recurrent burping and abdominal bloating. There was no history of flares of cough in the past 2 years. She has not used any inhalers in the past, but she took over-the-counter cough syrups with which she had only minimal relief. She did not have any associated nasal symptoms, no frequent throat clearing, no
Thomas,
change in voice.
put the, sorry to interrupt, you can put the slide on the slideshow mode, full screen.
Okay.
Is it full now?
Not yet. Not yet. Yeah, now it is.
So she did not have any associated nasal symptoms, no frequent throat clearing, no change in voice, no difficulty in swallowing, no contact with tuberculosis, And there was no red flag signs such as hemoptysis, loss of weight, fever, chest pain, or recurrent chest infections. She did not have any significant past history. There was no seasonal breathlessness or cough or wheezing episodes, no tuberculosis in the past or malignancies or diabetes or hypertension. Her family history also was non-contributory to her present symptom of dry cough. Her personal history, she was a never smoker. She does not chew tobacco. But on a leading question, she gave history of having around 50 pigeons at her home, and she was involved in cleaning and feeding them. She did not have any air cooler at her home, and she did not have any biomass fuel smoke exposure. Her sleep was normal. Bowel and bladder habits were normal. She lived in a Pakka house with good ventilation and belonged to a lower middle class family according to a modified Kupswami scale. Her clinical examination was unremarkable. With this history, the differentials that we would consider are gastroesophageal reflux disease related cough, a possible cough variant asthma, or a hypersensitivity pneumonitis because of the pigeon exposure, even though the clinical examination was unremarkable. Thank you.
Okay. Thank you very much. I think before we discuss the case, I think again we will discuss the pathophysiology of cough, and Dr. Anjana Talwar would be discussing the same. Dr. Anjana, please.
I am not able to share it.
Ma'am, there's an option called as share screen at the bottom.
Pardon?
There's an option called as share screen at the bottom.
The bottom. That's what I'm trying to locate, but I can't see.
Saurabh, can you assist, please?
Can Dr. Thomas share his screen? Then only Dr. Anjana Talwar can share.
Dr. Thomas, please stop share.
Yeah, I have stopped sharing.
Okay. Ma'am, is it available? Is it visible
No,
to
I
you?
can't see. No.
It would happen now. Dr. Thomas has stopped sharing now. It would happen now.
Okay, let me see. In more, probably. Can't see the sharing option anywhere.
There is an option, admin, you can take control, help her, logging into her laptop. Admin can take control through the setting.
Ma'am, at the below center or the upper center, you can see a green button, share screen. Kindly hover your mouse over there.
I can share the screen in the sense that there is no green button anywhere. I have a few buttons below, more settings, reactions, that's all. And on the top, recording and nothing additional.
Ma'am, did you receive my mail?
Which mail?
I have just sent you an email. Just share your PPT on that email, ma'am.
Okay.
I will share it from my end.
Fine. Yeah, I've just sent.
Ma'am, didn't get your mail as of now.
I've sent it already. Shall I send it again?
Doctor, just check the email ID. Sanjay has put the email ID on the chat box. Have you sent on the same email ID, sanjay.pal@glenmarpharma.com?
Yeah, sanjay.pal@.
Yeah, yes, I just got it, ma'am. Just got it. Just got it. Visible? Screen is visible? Ma'am, screen is visible to you?
Visible
Yeah.
to me.
Okay. Yeah, you can go on.
Yeah, okay. So today, sorry for the problem and in joining and then connecting also now. So I'm going to deal with the pathophysiology of cuff reflex. So you will be handling it at your end? As you're
Yes, ma'am,
sharing
I'll be
slide?
handling. Yes, I'll be handling.
We can go on to the next slide. So I'll have to prompt you every time. So the cuff, as we all know, you're familiar, it is an exclusive expiratory effort that provides a normal protective mechanism for clearing the tracheobronchial tree of secretions and foreign materials. The protective mechanism means the removing all the mucus, noxious substances, infectious organisms from the airways, that is larynx, trachea, and large bronchi. It prevents the pulmonary aspiration and clears the airway debris also. Each cuff is occurring through the stimulation of a complete reflex arc. That is important. So now going on to the next slide. there is normally, as we say, it is a protective mechanism. There is a cuff balance which is to be maintained. The normal cuff is responsible for the defense mechanisms in health and disease, whereas an imbalance in the cuff, if it is inadequate, that is ineffective cuff, could lead on to recurrent pneumonias, whereas if there is chronic cough, it decreases the quality of life and also causes symptoms for indicative of an underlying disease. Next, please. The frequency of cough can occur as a normal defense mechanism, so it can occur in a healthy individual. A study done for the cough frequency in health and disease in 2013 indicates that the total cough frequency per 24 hours in healthy individuals, 44 in number, was 18.6. The sensitivity of the cough or the frequency of the cough was more in females as compared to males. Whereas the frequency of the cough, if it is due to any respiratory disease, which were the patients were 78 in number, was on an average 275. Here the assessment was done based on the visual analog score and the questionnaires. Next, please. Now, as we say that cough is due to stimulation of the receptors, so the receptors for this cough are present not only in the upper airways, that is when we talk about it is the pharynx, larynx, supralaryngeal area, paranasal sinuses, but also then going on to carina, the bronchial branchings, the bronchi, pleura, pericardium, and diaphragm, and in addition, stomach and esophagus. In addition to it, even the external auditory canal and eardrum have got the receptors. So the cough could be stimulated by stimulation of the receptors in any of these areas, whereas these receptors would be stimulating certain afferent nerves. Please go on to the next slide. So there is stimulation of the cough receptors, which we saw on the last slide. They are present abundant in all the locations, which are again shown here. The reflex arc means the message from the receptors is taken by the nerves, that is afferent, which is then taking it to a controller in a normal reflex control, and then efferent, which take the message away from the center and then to the effector muscles or other effectors. So here in the cough reflex, we have the receptors which are shown here, starting from the larynx to stomach and esophagus on the left here. And the afferent nerve here are the branches of vagus. Then we have the cough center as the controller, which is at the nucleus of tractus solitarius, close to the respiratory center in there. And it can be modulated by the higher centers from the cortex as well as some other areas. The efferent from the cough center is taken via the efferent nerves, which are the spinal motor nerves taking the message to external intercostals and expiratory muscles, and the phrenic nerve to the diaphragm, and to via the vagus to larynx, trachea, and the bronchi. Next, please. So coming on to, after viewing the receptors, now we are talking about the afferents. So afferents, now we are taking, it is the endings which are there. They are of three types. One is the C fiber ending, which are unmyelinated. Then we have the endings from the RAR, that is rapidly adapting receptors. And then the third type is from the slowly adapting receptors. So the main stimulus for the C fiber endings are the thermal and the chemical stimuli. The chemical stimuli are so many, that is bradykinin, capsaicin, hydrogen ions, and in addition, smoke, smog, so many of them are available. Number of chemicals from the cigarette smoke itself are enormous, and the pollutants. And these C fiber endings are relatively insensitive to mechanical stimulation and lung inflation. Then RAR, that is the rapidly adapting irritant receptors, are sensitive to mechanical stimulation, reduction in the lung compliance, change in the diameter, as well as the length of the airways. And they are relatively little sensitive to changes in the pH and the osmolality. But to other chemicals, they are irresponsive. generally. The slowly adapting receptors are highly sensitive to mechanical forces, and they are the main receptors for the Herring-Brewer reflex, as it was shown in the earlier case discussion by Dr. Satya. That is, they are mainly responsible for the Herring-Brewer reflex, but they may influence cuff reflex also. So these are the main three afferent endings, that is rapidly adapting irritant receptors, C fiber endings, and the slowly adapting receptors. The conduction velocity of the C fibers is less because they are unmyelinated, less than 2 meters per second, whereas from the irritant receptors, they are thinner myelinated, having a conduction velocity of 4 to 18 meters per second, and then thicker are the slowly adapting, which are the ones for the Herring-Brewer reflex. These are more than 18 meters per second. So now we have the three types of nerve endings, that is, and the nerves taking the message: unmyelinated, thinner myelinated, and then thicker. Then the location throughout in the pulmonary tract, the C fiber endings are present throughout the airways and the lung. In fact, the C fiber endings are present from the upper part, from the nose down to the lungs, but for the cuff reflex, the receptors which are present in the nose are obviously not that important. They are for the sneeze reflex. Then rapidly adapting receptors are present in the intrapulmonary and extrapulmonary airways, more on the intrapulmonary airways. And slowly adapting receptors are primarily in the intrapulmonary airways. Within a structure, when these receptors or endings are present, they are the C fiber endings are present. That is, they innervate the airway epithelium superficially at the epithelial level, so that there is exposure to the chemicals to the endings directly. And RAR are present within the epithelium and beneath, whereas slowly adapting receptors are close to the smooth muscles and in the smooth muscle layer. Next, please. The C fiber endings, when we say that they respond to bradykinin, capsaicin, and citric acid, they are directly activated. That means they have the receptors which are present there directly at the end, which are two of them are written there, that is like TRV1 and TRA1, which we'll be talking about in the next slide. Then RAR bring the effect relatively. Some effect is seen, which is not directly due to the presence of these receptors, but it is indirectly through the effect on the diameter, length, and compliance. So if there is any bronchospasm or some edema there and the compliance is affected, then RAR get activated. And this can be differentiated by seeing the response with the presence of prostaglandins, adrenaline, and adenosine. When they are there, they sensitize these C-terminal fibers to the capsaicin and bradykinin by acting directly on the sodium channels which are present there. And so this is a direct effect, and sensitization occurs. That means the response to capsaicin and bradykinin can now occur at a lower dose or lower level. Whereas in the presence of these prostaglandins, the RAR activation by bradykinin and capsaicin is inhibited because of bronchodilation. Next, please. So just now we said the stimulation of the C fibers, the chemical stimuli which are acting, that is capsaicin, which is a product. It is present in the chili pepper. It is a vanilloid extract of pepper which is there. The mode of action is it has got the receptors which are TRPV1, transient receptor potential vanilloid 1, and the endings are on C1, C fibers. Bradykinin acts through the B2 receptors, the bradykinin receptors, and the endings are again on C fibers. Hydrogen ions act through the TRPV1, and then there are acid-sensitive ion channels specifically, and the message is taken via the C fibers, and there are some cuff receptors connected to A delta fibers independent of the capsaicin and bradykinin effect. So they are independent of that TRPV1 and A1. There are independent channels. And the particulate matter again is stimulated by these cuff receptors and C fibers. These cuff receptors were first initially seen in guinea pig, that they are able to bring about the cough even in anesthetized animal. So, and carrying the A delta fibers. The A delta fibers carry the message, and this effect is independent of the other fibers which are carrying the message from TRPV1 and A1. TRPA1 agonists are like in smoke and smog, then we have chlorine, and then the reactive oxygen species. They are the ones which are acting through the TRPA1 receptors, and the again the afferents are C fibers. Then prostaglandin acting via the EP3 act through C fibers. So nicotine via the nicotinic receptors. So these are some of the chemicals which can stimulate the C fibers, and they are potent stimuli, that is capsaicin and bradykinin. Next, please. So coming to the triggers, now we just now said, there are so many chemicals. That is, we have talked about a few chemicals per se, but smoke, perfumes, any irritation of the throat could affect, or there are noxious fumes carrying some chemicals. And while exercising also, there could be stimulation of the chemical receptors or the mechanical receptors, the cold air, and while eating also some irritant can stimulate. So these are some of the common triggers. There would be many more. They would stimulate the receptors which have been shown earlier. That is, one is TRPV1, TRPA1, RAR, SAR, and these messages are then taken via the vagus nerves, that is the myelinated and unmyelinated C fibers and the A delta and other fibers. And the message is directly taken to the control center and influenced or modulated by the cortex and bring about explosive expiration or cough. The next, please. So the mechanism of cough with each reflex arc being completed starts with the irritation of the airways by or the various stimuli which are acting on the receptors. As a result, this is then followed by the first phase of coughing, which is the inspiratory phase shown in here in the diagram. And during this phase, the vocal cords open widely, allowing more amount of air to enter the lung for inspiration. And this inhalation generates the volume which is necessary for an effective cough. And for this, the external intercostal muscles and diaphragm then contract, and the movement of the rib cage and chest cavity occurs, leading to entry of the presence of air in the lungs. The second phase is the compression phase. During this phase, there is closure of glottis, and expiration then occurs against a closed glottis. There is increase in the intrathoracic pressure which occurs due to the contraction of the internal intercostal muscles and the starting of the abdominal muscles which start contracting along with them. So this is the compression phase which is occurring, to be followed by phase 3, which is expulsion, during which, due to an increase in the intra-abdominal pressure and the intrathoracic pressure, the glottis opens and there is expiration or high expiratory airflow is there, and a coughing sound is also produced. During this phase, there is compression of the large airways that is responsible for mainly for the sound which occurs while the high flow air moves through it. Along with this airflow, there is mucus which is present there, is dislodged from the airways and is removed from the tracheobronchial tree, carrying out the defense function which is required. So during the vigorous coughing, the intrathoracic pressure may reach up to 300 millimeter of mercury, and expiratory velocities also increase enormously. Next, please. So during the 3 phases of the cough, which we have just now mentioned, There are changes in the flow rate, subglottic pressure, and the presence of the sound, which has been shown here, and change in the volume, not shown in this particular slide. And as it is shown here, in this second phase, when the glottis is closing, the subglottic pressure starts increasing. And as it reaches the peak at the highest value, say about more than 40 centimeter of water, maybe 45 to 50, it can go much more also. There is then opening of the glottis, and then the pressure decreases. Now, in the flow rate also, similarly, there is an increase in the flow rate towards the end of the second phase. And then in three phase, when explosive expiration occurs, there is an increase in the flow rate, which slowly decreases to start coming towards normal. In addition, the sound which is seen is in the phase 3 because of the high flow of the air and the compression of the airways. The sound is produced, which can be assessed by using a microphone in the whole setup. When we are this equipment was used to assess all this. Initially, the first study was done in 1966, where this type of graph was obtained, and based on that further studies have been done. So in that, they used a small microphone which was attached to the setup, and the sound could be heard in the third phase. So this can be used to assess the cough frequency. Next, please. So this is occurring with each cough. So the types of cough an individual can have could be acute self-limiting, the causes of which are stated here, and you all are familiar with them. That is upper respiratory tract viral infection, bronchopneumonia, viral pneumonia, pertussis, exacerbations of eosinophilic asthma, and exposure to the environmental pollutants. Or it could be chronic persistent. The first one is less than 3 weeks, being acute self-limiting. The second is chronic persistent, being more than 8 weeks, in which the causes are asthma, cough variant asthma, eosinophilic bronchitis, gastroesophageal reflux, rhinosinusitis, postnasal drip, and ACE inhibitor induced cough. The subacute could be between 3 to 8 weeks. The common causes tracheobronchitis, pertussis, and post-viral tussive syndrome. Next, please. So when a person can have a beneficial effects due to coughing, due to chronic cough, that is, there is exhaustion. The person becomes very conscious while in a meeting, especially now in the post-COVID area. If one coughs in any meeting or any gathering, everyone starts looking at him that probably he's suffering from COVID. So insomnia, headache, dizziness, musculoskeletal pain, hoarseness, excessive perspiration, urinary incontinence can occur. Multiple rib fractures, that is, most common ribs affected are 5th to 7th, and this complication would occur more commonly in women who are prone to osteoporosis in later age. Next, please. Now, these are the pathways, that is, these are the representative pathways which are shown from the epithelium. This is the structure of the airway, and the rectangular structures here are the epithelial cells. In between, we have these 3 types of black fibers, and having these red as the receptors for them. That is the cough receptors, as well as the receptors which are present on the RAR and C fibers. Now, in all these fibers, that is, which are shown here, that is C fibers, RAR, as well as from the slowly adapting receptors near to the smooth muscle below, and the A delta, the fibers, the message is taken, and we have talked about it earlier, to the brainstem, nucleus of tractus solitarius, relay neurons, and then to the central cough generator, and then the contraction of the muscles occur through the efferents, and finally cough. On the top, we have the role of the cerebral cortex of neuromodulation being shown, that there is a voluntary control of the cough which is possible, and also urge to cough. That is, they have a special role in the urge to cough, where the sensory cortex has a role, which was shown here. The position earlier for the sensory cortex was shown in the earlier case discussion. So they get stimulated there, the sensory cortex, in the cough reflex also, and there is this urge to cough. Now, in addition, in this diagram, we have seen these three type of nerve endings are contributing to an inflammation which is referred to as neurogenic inflammation. Why? Because it is occurring due to the release of certain mediators from these afferent nerves via the local axon reflex. So through the axon reflex, certain mediators and neuroproteins are secreted, CGRP and substance P, and neurokinin. So they are being released and are responsible for the vasodilatation as well as the edema. So they bring about, and the bronchial diameter changes. So they further bring about the changes. Now the bronchospasm is there because of the stimulation here, because of the histamine and LTD4 from the eosinophils and the mast cells respectively. And in addition, what is shown here is on the epithelium, there are TRPV1 channels, and in addition, hydrogen ions, which are shown through the acid sensitive channels, which would be acting. And then there is CGRP, which is mediating the effect here. So presence of mediators like TNF alpha, which I'll be showing you probably in the next slide, could have a role for bringing about chronic cough. Next, please. So the peripheral pathways, in addition to what have been shown in the last slide, this was exogenous pathway. Exogenous pathway means all the irritants which are acting here are coming from outside. They could be any particulate matter, it could be capsaicin, it could be due to cold air, it could be due to any other chemical to which, or mucus, to any other chemical to which the airway lining is exposed. Now, the message here is taken by these magenta colors shown vagus nerve, and this is just a part of the stimulating pathway, that is exogenous pathway. In addition, now an endogenous pathway, so this stimulation of the exogenous has acted through TRPV1, A1, and in addition, there are further channels like TRPM8 also, which is there, which has been shown. And the endogenous pathway is the ATP dependent. That means it is due to the release of ATP endogenously during inflammation, and it acts on the P2X3 receptors. So it is not only just the exogenous triggers, but endogenous levels of ATP during inflammation or other cellular stress could also lead to stimulation in chronic refractory cough. So when ATP has a role in the chronic cough, it can be worked out that its antagonist, which is gefapixant, can reduce the cough response to the inhaled ATP only, whereas if the other products have a role like capsaicin and bradykinin, then it would be the antagonist for the TRPV1 and A1, which could block the effect. So normally the experimentally induced decisions are capsaicin. They cause the cough through the exogenous pathway and not through ATP, which is endogenous. So this is the now in the peripheral pathway, an addition, that is endogenous pathway through which is ATP dependent. Next, please. So the role of, yes, please. The role of the higher centers, that is cortex, has been shown through the functional MRI studies that during urge to cough, which is evoked by inhalation of capsaicin, inhalation of capsaicin has been standardized, and it has a good dose response curve. The amount of dose which can produce 2 coughs or 5 coughs has also been standardized. So here the urge to cough evoked by inhalation of capsaicin is associated with activation of many areas of the cerebral cortex and cerebellum. So insular cortex, anterior cingulate cortex, primary sensory cortex, and the cerebellum are showing the effect, demonstrating that there is a cortical influence on cough. Next. So in chronic, next slide please. So in chronic cough then, this higher modulation is very important because the chronic refractory cough is the one which is associated with probably increased sensitization. This increased sensitization could be through the peripheral tract, which was shown in the last slide, that is exogenous or endogenous, and it could be through the central mechanisms. The central mechanisms here which are shown are, that is, there is, apart from the cuff center which is there in the brainstem, we have sensory cortex having a role in the sensation of cough and throat irritation and urge to cough. The midbrain, which is nucleus cuneiformis and periaqueductal gray, and the forebrain, that is prefrontal cortex, anterior and mid-cingulate cortex. So all these have a role in the cough. Normally, during chronic cough, there is hypersensitivity, probably which is due to the reduction in the inhibitory mechanism, this inhibitory pathway from the cortex going to the cuff center has a reduced action. That is, normally it is inhibitory. So if it has a reduced action, that means cough would be stimulated. In addition, via the unknown mechanisms, there is increased activation of the cuff center from the midbrain areas, that is the nucleus cuneiformis and periaqueductal A. Can you show the written material here? So, so the cuff center is stimulated by the cortex. This shows inhibition, cuneiformis and periaqueductal A, which is probably responsible for more sensitivity. It gets excitation. So there is probably, these two are the reasons which are responsible for the hypersensitivity. In addition, the lower levels of the exogenous stimuli, which normally do not produce the effect, or even normal physiological levels of ATP in the body, in the cells, could be a cause of cough. So they now can be stimulated because the central mechanism has a more of excitatory effect, and from the periphery also the sensory processing is being affected. The modulation of the sensory processing also occurs at the at the level of vagus nerve ganglia, which also becomes very relevant. Next, please. So just showing here further that the various inflammatory cells release the inflammatory mediators, pro-inflammatory mediators during chronic cough, and these mediators, which may not be normally present there, are responsible for bringing about activation of the receptors which are present at the nerve terminal. So they get activated and sensitized to the regular presence of these inflammatory mediators from the cells which are released there, inflammatory cells like neutrophils, eosinophils, macrophages. So all these in monocytes which are their mast cells, so they will be releasing the chemicals, and the chronic presence of these chemicals and the activation of the nerve terminals would then lead on to the neuroplasticity. That means those cells, those receptors which were activated now, they are leading on to opening of certain ion channels and leading on to the increased sensitivity and the effect of coughing. So there are certain receptors which, that is TRPV1 and A1, they are mediating their effect. They are basically the cation channels acting through the opening of these cation channels being shown here. So initially, if they were not active, now due to the continuous presence, they get activated, and then it go on to stimulation of plasticity. So we can know that the system which is working here is endogenous or not, we can give the inhibitor for the ATP and see the effect. But in humans per se, these type of experiments are not done those regularly, but we can give the antagonist of ATP and see the effect. And also when inhaled ATP is given, the effect is seen to in a particular way to produce cough, that is having the afferent activation of the nerves, and the action potentials are generated there. Everything can be recorded and we can see the effect via the exogenous or endogenous. Now, just now I talked about the central imbalance in the excitatory and inhibitory pathway, which was shown there in the last slide. That is inhibitory for descending influence from the cortex, and excitatory is coming from these midbrain barriers. So whether a balance can be restored or not, this is very important to restore, and there are certain drugs which can target it, like NK1 antagonist and also the GABA agonist, as well as nicotinic acetylcholine receptor agonist. So these drugs have been tried, but there are mixed results. Next, please. There are clinical trials done. Mixed results are there. Excuse me. So we have seen in the mechanism of coughing that normally the pattern of cough would be first deep inspiration, and then followed by the forced expiration against a closed glottis, and then expiration with high airflow velocity, explosive expiration. So normally, when the stimulation is done distal to, there is stimulation distal to larynx, the inspiratory phase is more pronounced, and high airflows are thus generated to remove the stimulus from the lower airways up to be removed. Laryngeal stimulation produces a choking type of cough in which there is no full-fledged inspiration. There is an immediate expiratory stimulation to protect the airways from aspiration. In addition, when there is inadequate mucociliary clearance, as in cystic fibrosis or bronchiectasis, there, because of the less removal of the mucus due to defective mucociliary clearance, coughing is less violent. That means the acceleration of the air which can occur in these airways with mucus present is less, and and a sequence of interrupted repeated expirations occur without much of intervening inspiration. Next, please. So what would be causing the ineffective cough? That it is not able to carry out its normal function of defense. It could lead on to atelectasis, recurrent pneumonia, chronic airway diseases. It could occur when the cough reflex is compromised, as in elderly, in newborn, and in lung transplant recipients, and also in patients having neuromuscular disorders where the defective pump mechanism is there, chest wall deformities, and reduced function of the abdominal wall musculature. Low flow rates would occur when there is a floppy airway, that is in tracheobronchomalacia or obstructive airway diseases. Insufficient laryngeal closure could occur, as in laryngeal disorders or in tracheostomies. So there is inability to generate the increased intrathoracic pressure, so that cough may become ineffective. During sleep also, chronic cough is suppressed to a large extent. Next, please. So chronic cough, through the, earlier also it was there that the angiotensin converting enzyme inhibitors can lead on to chronic cough. And this occurs due to accumulation of bradykinin, which is normally degraded by angiotensin converting enzymes. As a result of that, there is accumulation of bradykinin, and they will stimulate the afferent nerve fibers, and C fibers being stimulated would bring about cough. Angiotensin 2 receptor antagonists are useful in this respect. Lesions compressing the upper airway would bring about chronic cough, including arteriovenous malformations and retrotracheal masses. Then we talked about the floppy airways, that is with loss of rigid support of the large airways and inspiratory collapse, and laryngeal sensory neuropathy, where the cough onset is acute associated with laryngospasm. Next, please. So, in addition to it, chronic tonsillar enlargement, irritation of the external auditory canal by impacted foreign bodies will bring about chronic cough. The mechanical stimulation of the auricular branch of the vagus nerve occurs in the ear. This is the Arnold nerve, and this is called Arnold's nerve reflex. Then there could be an autonomic dysfunction affecting the vagus nerve called Homer's-Eddy syndrome, which would be associated with other features of autonomic dysfunctions. And then there could be habit cough or a psychogenic cough, which would not be there during sleep. Next, please. So how can we assess cough? We said cough frequency, each frequency indicating one complete reflex arc. So there are cough monitors which will help in assessing the cough frequency. In addition, we can check the cough reflex sensitivity, which can be assessed by controlled inhalation of certain protussive agents like capsaicin and citric acid, and this would then be indicative how many coughs are there associated, which can be recorded. Next, please. I think with this, I've given whatever is essential for the cough reflex, and this lecture is useful to you. Thank you.
Thank you, Dr. Talwar. I think that was a very kind of detailed discussion on pathophysiology or physiology of cough, you see, and you have explained the different causes of cough, the mechanisms of cough in different respiratory diseases. And I'm sure the participants of the audience will must have learned a lot about the mechanisms of cough and pathophysiology of cough, you see. Now, going back to the case, I think we'd like to share my few slides on this case, which has been presented earlier by one of our resident doctors, you see. Can you all see the slides? Hello?
Yes, sir. Slide is visible, sir. You can put it on full screen mode.
Okay. So I think approach to cough is in the same fashion as has been done for breathlessness or perhaps for any clinical case. History and physical examination and clinical setting, patient, whether it is a acute kind of condition or ambulatory condition, the onset for how many days, hours, or weeks, or months, then age, severity of cough, and associated symptoms. Associated symptoms are always important in all diseases, including cough and breathlessness, you see. Then investigations, chest radiology being most important, and then other lung function tests and so on. You see, we will not go into the details at this I think that is the general algorithm which is followed while finding the cause of cough, review of history, and most importantly, one has to differentiate between productive and non-productive cough. Productive cough with sputum, etc. Multiple diseases like bronchiectasis, lung cavity disease, fibrocavitary tuberculosis, lung abscess, and even in chronic bronchitis and chronic obstructive pulmonary disease. While non-productive cough or dry cough can occur commonly in simple post-nasal discharge syndrome or asthma, COPD, and many other causes. So we can broadly divide the causes into these two categories. And then, of course, the chest X-ray is done. Again, can be divided broadly into two categories, normal or abnormal. If it is normal chest X-ray, again, you will think of non-respiratory or general causes, smoking, some drugs, or following viral infections, upper respiratory tract catarrh, and or GERD, etc. So the algorithm which is followed here would be just to discontinue those things which are supposed to be responsible and see the symptom relief. You see, whether it persists or it is relieved. If relieved, okay. If it persists, then you have to investigate further with the radiology, spirometry, and other things. Of course, if chest X-ray is abnormal, then the line of approach becomes somewhat different, because you have to investigate here, do chest CT scan. If then, depending upon the cause or suspected cause, you see, if you suspect a diffuse disease like ILD, then perhaps CT is the first thing. Then bronchoscopy, lung biopsy, and others would be required, you see. So in this case, I think this case is a bit kind of simple in that sense, that very short, very kind of simple history of dry cough for 2 years, which have been persistent during day and night. There are no postural variations, no definite triggers. I think that is important. As I said earlier, sometimes negative histories are even more important than positive histories. So that is that there is no definite known trigger, but there could still be triggers for the problem. You see, the patient also had complaints of recurrent burping and abdominal bloating. You see, with no history of other flares, no prior use of any inhalers. I think that is also important, because that may indicate the suspicion of obstructive airway diseases. She has been a never smoker. I think that is other important history. And there are no air coolers at home, no biomass fuel exposure, etc. Important history is available that she had pigeons at home, around 50 at her home, and was involved in cleaning and feeding them. I think this indicates a great exposure to the pigeons, kind of, especially their feces and so on, you see. And the clinical examination was, of course, unremarkable. We do not have any kind of investigation given to us in this patient, but so the important things to note are that this patient, a 45-year-old female, has been having dry cough for 2 years, some abdominal symptoms, not smoker, but exposed to pigs at home. So I think this limits our differential diagnosis to 2 or 3 things, as has been said by the presenters. One, of course, is the gastrointestinal reflux or gastroesophageal reflux syndrome, that mostly in view of burping and abdominal bloating, you see. But I won't say that there is any, because, for example, on lying down or in the morning, there is no significant worsening. There is no history of regurgitation as such, you see. So I won't consider it as a predominant diagnosis. It is more of burping, abdominal symptoms, you see, rather than of regurgitation symptoms. The other cause given was cough variant asthma. It could be possible. Cough variant asthma is always can be considered in such a patient, although there is no history of variability of cough or other obstructive symptoms, you see, or of cough. No daily variations, no use of inhalers. So again, I will not keep it as a prior kind of priority diagnosis. The third is the hypersensitivity pneumonitis. I think that is an important diagnosis to consider in view of the consistent symptom of or persistent symptom of dry cough for 2 years. And then, of course, the exposure to pigeons, you see, significant exposure to the birds, you see, that the bird fancier's disease or hypersensitivity pneumonitis, and incidentally, exposure to pigeons is one of the most important cause of hypersensitivity pneumonitis caused interstitial lung disease in this country. We have to investigate this patient further with the help of spirometry, one thing, chest radiology, and perhaps even high-resolution CT scan. And if need be, one can also give a kind of do the antigen testing, although they're not always useful. These kind of IgE testing, and if you can really find the antigens from the pigeon excreta, it would be almost diagnostic, but it's not. Most of the time, it's not feasible. You see, you can do serological examination against that. Those antigens which are commercially available, that can also be done, and that may give a fair good indication, you see. So I think these investigations are not given here, but our suspicion will remain to that diagnosis. Or sometimes for clinical purposes, for treatment purposes, one can consider it as a confirmed diagnosis, although for real confirmation, you see, or documentation, it would be important to do other tests. No, I think the details about cough, its physiology, and other things have already been talked about by Dr. Anjana Talwar. It is a defense mechanisms to clear the respiratory tract of inhaled material, mucus, secretions, edema, pus, etc., etc. Or it can be irritant cough, which is simply a receptor stimulation. And sometimes it is a warning symptom of an illness like underlying tumor or interstitial disease. So primarily it is a protective reflex, you see, the cough, presence of cough. But when severe, it becomes a major decrement, as has been shown earlier. One must always try to see the spectrum of cough, whether it is minor annoyance or it is a serious disease, because these are the two extreme kind of ends of the spectrum. Acute and short, again, which can be easily treated, but on the other hand, some patients have chronic and persistent. It could be effective cough or weak cough, as has been shown. It could be a warning signal, as has been discussed, or it could be a useful symptoms. So dry and productive. So these are the different kind of ends of spectrum of cough, which are widely variable. Acute cough or chronic cough, and then there is also a terminology called subacute cough. So acute cough, when it is longer than 8 weeks chronic cough is longer than 8 weeks in adults or 4 weeks in children. And the common causes have been discussed. You all know them. There could be other miscellaneous causes or relatively, you can say, general causes like reflux, ACE inhibitor, psychogenic or habitual cough, and so on. You say. So I think we'll not discuss into, because shortage of time perhaps, but It should also be kept in mind that that cough may not be necessarily due to one condition. This shows one analysis where the number of conditions causing cough in a patient can be more than one. Although most of the patients, 73%, only one cause, there are people with 2 causes, 3 causes, and 4 causes, etc. So multiple causes can always be there. And it is called refractory when it persists despite guideline-based treatment. And frequently that becomes a very important headache for a clinician, because there are patients who, in spite of all kinds of treatments, they would remain refractory, or sometimes it is intractable, that in spite of all the differential diagnosis, all the investigations, still the cough keeps on coming. You see, so I think those things should always be. And then the red flags, I think, which have been again shown earlier, which gives a kind of indication to the presence of a serious illness. You see, it could be very vigorous and hazardous. Cough syncope has been talked about. Sometimes those neurological complications in particular are very risky, and sudden death can also occur in such patients, you see. It could be ineffective cough, as has been discussed earlier. Sometimes you see, especially in patients with the neuromuscular diseases, weak, etc., etc., you see. So those things should always be kept in mind while talking about cough. Importantly is to remember that cough can be simple and ignored, but on the other hand, it could be very risky and sometimes even fatal. Well, thank you very much. I think we'll now go to the last part of the session of questions and answers. Yeah.
Just a second, before sharing the questions, there have not been receival of all the polls. So Shivani will share a screen, and we would like to tell the audience, those are students, how they should share their poll. Shivani, can you share the screen?
Yes.
Dr. Jindal sir, can we give around 10 minutes for the students for answering the questions?
Yeah, sure.
Okay, so all those who are on the webcast, kindly note that here there is a submit button. Above it, you can share your questions, and just below it, you can see the poll button. Kindly click on the poll button, and you will be seeing the questions. Kindly answer those questions. You will be having 5 to 10 minutes. After that, we will be starting Dr. Deepak Talwar's video of the question answers. Thank you. Over to you, Dr. Jindal sir.
Do I present?
Yeah, no, sir. Meanwhile, we can take up the questions which are there in the chat box.
Okay.
Sir, can I add something from the first case? Hello.
Yes, please.
Sir, in the end, the sleep study was done for the patient, which shows an HAI of 37.
Okay.
And give the impression of severe obstructive sleep apnea, sir.
Okay, so that's what we thought initially, that this is what is.
And a CPAT test was also done, sir, which shows a normal exercise capacity.
Okay.
Yes,
Okay, I think I can see some of the questions in the chat box. One by Dr. Neeraj Yadav is treatment options in asthma. I think that is a large kind of long answer it, but by and large it is the anti-inflammatory treatment given with inhalers. That's the first choice, and along with bronchodilators, I think mostly inhalational bronchodilators is given. Otherwise, it would depend upon the upon these kind of stage at which you see the different manifestations, etc. So the treatment varies hugely. One cannot say that it can be given only with bronchodilators or anti-inflammatory drugs, but in general, I think it should be the inhalational treatment which is preferred, and anti-inflammatory treatment with corticosteroids, inhalational corticosteroids, mostly with a long-acting bronchodilators. But we can discuss sometimes else, you see, this last question. Classical difference of breathlessness between cardiac and pulmonary case. I think, again, there are a lot of differences, but most importantly, for example, in history, the patient with the cardiac illness will be relatively shorter duration, respiratory can be longer, etc. So, but importantly are the features of cardiac illness should be present, both on X-ray, cardiomegaly, pulmonary congestion can be there, ECG, echocardiography, etc. can be done. But on, of course, then breathlessness, orthopnea is an important feature of cardiac diseases, left ventricular failure, but there could be a lot of overlap. But classical difference would be on history, at least it would be, I suppose, a presence of orthopnea and presence of a cardiac disease. How to differentiate dyspnea of respiratory cause versus systemic cause, you see, that's the other thing. Again, history is most important here, and there would be in a systemic cause, for example, whether it is interstitial disease, you could find some manifestation of a collagen disease, CTD, etc. Skin lesions, joint lesions, or other disease, multiple systems can be involved. Respiratory, you will find more of kind of respiratory symptoms alone. Again, there is some overlap, but most, I think, if there are clinical features of a systemic illness, both symptomatically as well as on physical examination, then it is important, and you will do investigations depending upon the suspicion, you see. How to calculate smoking index and pack years for BD and Chutta smokers? I think the Western pack year is not applicable for BDs and Chutta. That's why we on our own had come out with a smoking index several years ago, which was the number of cigarettes or BDs smoked per day multiplied by the number of years. We have slightly modified that subsequently because the number of cigarettes per day can be variable. So although it is on average, so it could be number of cigarettes smoked, BDs smoked per week into number of years. So that can be done both for cigarettes and BDs, and it can be separately stated there. Chutta smokers and hookah smokers are not possible. It's not possible to classify them on this index, you see. There you have to use perhaps the weight of tobacco which is used daily if you really want to quantify. Next question is obesity can cause, this is the answer, I think, which Dr. Subramani has nicely given for obesity causing breathlessness. How to assess reconditioning in a patient presenting with dyspnea? Are there any investigations suggesting deconditioning? I think for deconditioning, the most important is the history, because that is what is apparent, whether patient has been sedentary or mobile, what is his BMI, that is more important, but exclusion of an underlying cause would be the other important kind of finding, and investigation directed towards those inclusions or exclusions. Is there any role of diving occupation in dyspnea of the first patient? I don't think so. He was a diver by profession, but divers' dyspnea is caused usually due to, it occurs due to pneumothorax, etc., or decompression syndrome, what we sometimes call, you see, the kind of, it is again a deconditioning condition, you see. That is acute. It does not occur on a long-term basis. And I am not sure whether it's a deep sea diver, because that would happen normally in deep sea divers, you see, not in routine divers in the canals and rivers, you see. So I think it is unlikely. That's what I will say for that patient. This is a question, I think, from Dr. Anjana, that how do we know it is the endogenous or ATP dependent pathway that is responsible for cough? Before she comes, maybe I'll finish the other two questions. The drugs for drug hypersensitivity. I think I am not clear what is the cough hypersensitivity. Sorry, cough. What is meant by cough hypersensitivity here? But generally, if it is a hypersensitive type of cough, you will like to give kind of irritant material inhalation, anti-inflammatory agent, stop the drug which is causing cough. That's what is most important. And otherwise, it would be kind of local inhalational drugs, anti-inflammatory drugs, and even bronchodilators. Local can be helpful, you see. Please explain MMIC grading system. I think that the slide is not there, but generally it is from grade 0 to 4, that once, depending upon the exertion, whether you feel breathless while walking on the person of your age, or you can feel breathless on level walking or going uphill, or even at rest, etc. So depending upon the severity, you can always classify it. What can be used for chronic cough in ILD? I think that is normally, besides treatment of the underlying cause, you will like to treat them with cough suppressants. And if not, then if patient does not respond, because it is quite common for them not to respond, then you can use some strong sedatives, cough suppressants, including benzonatate. You will try, and codeine, of course. Codeine is a very strong cough suppressant. Some, unfortunately, not available. So you have to choose the drug depending upon the response of the patient. Is dry cough after ruling out usual causes? Can we go through cough suppressant? Yes, I think if you have ruled out usual causes, you can certainly use cough suppressants, but your effort to find the cause should continue. Antibiotic use indication in upper airway cough syndrome. Normally, there is no use of antibiotics because most of the time it is viral or allergic in origin. But some people say the macrolides have anti-inflammatory role that have been used. So if patient is not responding to routine antihistaminics or cough suppressants, perhaps you will like to use it. But all these conditions, all these indications would depend upon the response of the patient, the type of patient, as well as on the other underlying diseases, etc. Well, thank you very much. You see, I think it is difficult to go into details because of the paucity of time.
Yeah. So now we can play Dr. Talwar's video. Saurav.
Sure, we will start Dr. Deepak Talwar's video of the question and answers.
Yes.
Yes, so there was, can you hear me?
Yes.
Hello? Yeah. So the one question which is there is that how do we know that it is the endogenous or ATP dependent pathway which is responsible for cough? So that would be that the cough would not respond to the other antitussive which are directed against the chemicals. That is TRPV1 and TRPA1 pathway. From that, there would be no response. And this cough, which is there due to the endogenous or ATP, would respond to its antagonist. That is, I've given the name. So this is just that if you give that antagonist, the chronic cough would respond, whereas to the if it is due to the endogenous ATP, it will respond with the antagonist of ATP acting on P2X3 receptor, and the other will not respond. So it's as simple as that. But how clinically available these drugs are, that a clinician would probably be the best one to answer.
You have finished today's module and must be waiting for seeing the results of the 20 pre-test questionnaires which we had given to you. So if you have not done it because you joined late, there is still point that you can go ahead and guess these questions, write down on the piece of paper and send it to across by email. First question was, which phase of cough has glottis closed? And obvious answer is compressive phase, C, because that is the time when the glottis is closed and compression occurs so that there's a lot of force created and you can expel it out. Question number two. Cough reflex will have all these features except cannot be voluntary, is voluntary, involuntary, is protective, has a cough center. We know there is a cough center. We know it is protective because it protects us from aspiration. Is involuntary, we know, but yes, it can be voluntary. I can cough, so that is voluntary. So it is a voluntary reflex and it is the only reflex in the body which can be produced voluntarily. Question number 3. Cough receptors are seen in all these organs except paranasal sinuses, eardrum, esophagus, pericardium, and pulmonary artery. So all these organs which are extrathoracic can have cough receptors, or rather have cough receptors and can produce cough. Pulmonary artery is the only system or the only organ which does not have cough receptors. So the answer is E. Question number 4. Cough can be stimulated by all except. So there are many chemicals which can actually drive cough: nicotine, capsaicin, bradykinin, prostaglandins, and histamine. So only histamine is the one which does not produce cough. Rest all of them produce cough. Next question, number 5. Pathophysiology of cough hypersensitivity syndrome is due to all of except. It is like a self-perpetuating hypersensitivity leading to cough and more cough. Excessive vagal stimulation, exogenous pathway outside lungs, endogenous pathways outside lungs, inside lungs, increases cortical inhibitory influences and physiological concentrations of chemicals. I do not know what you have answered, but even physiological concentration of these chemicals can induce cough because it is hypersensitivity response. And it is a cortical inhibitory influences which are decreased to stop the cough. So increase in cortical inhibitory influences will actually try to suppress the cough. And if it is increased beyond a limit, then obviously the hypersensitivity syndrome comes because it is not able to inhibit the cough. Next question. Question 6. All are the causes of acute cough except viral infections, exacerbations of chronic lung disease, pneumonia, malignancy, and heart failure. And malignancy is the answer. Next, question 7. All are the consequences of chronic cough except subconjunctival hemorrhage, syncope, fractured ribs, urinary incontinence, and seizures. So seizures is something which does not happen with chronic cough, even if they get syncope. So if they get seizures, that's a red flag. Next question. Question number 8. All are causes of chronic cough except bronchial asthma, drugs, GERD, chronic rhinosinusitis, and pulmonary embolism. Again, pulmonary embolism is the one which primarily does not cause cough. Next, question number 9. Following tests are useful to investigate chronic cough, like chest imaging, sputum for CB-NAT, spirometry, X-ray PNS, and bronchoscopy. So least useful is bronchoscopy. Next question. All are used in the treatment of chronic cough except neuromodulators, narcotics, long-term macrolides, speech modulation, and involving MDTs. All are correct except one, and that is long-term macrolides. MDT involvement is very important because generally 3 or more than 3 causes of cough are there, and which will be like in the ENT domain, gastrointestinal domain, pulmonary domain, or cardiac domain. Next question. In the treatment of chronic cough, all is recommended in the first line except inhaled steroids, gabapentin, PPI, oral steroids, non-opioid antitussives. Oral steroids are discouraged and rest all can be used being safe. Next, please. Breathlessness is the next question about breathlessness is perceived at what level? At the level of chest, that is thorax, at the level of lungs or brainstem, cerebellum or cerebrum. So it is perceived at the level of cerebrum. So cortex is the one which is responsible for perception of breathlessness. Next question. Dyspnea can be produced, perhaps stimulated by all of the following except, that is hypoxia, hypercapnia, hyperinflation, emotions, or lung deflation. So once the lung gets hyperinflated, it leads to stimulation of dyspneic receptors. Lung deflation, on the other hand, does not stimulate the reason to perpetuate dyspnea. Next question, please. Dyspnea reflex has afferents in all of the following except respiratory muscle, chest wall joints, pulmonary vasculature, cardiac muscle, and lung interstitium. And the answer is cardiac muscle. Next question. All of the following have dyspnea reflex receptors present in the following tissues. So only one of them it doesn't have. So facial skin, cerebral cortex, aortic bodies, carotid bodies, and pulmonary C fibers. So cerebral cortex is actually the perceiving center. So it is not the receptor center. So answer is cerebral cortex. Rest all of them are basically where the receptors for the dyspnea are present. Next, please. All of the following are the type of dyspnea reflex receptors except slowly adapting stretch, rapidly adapting stretch, peripheral chemoreceptors, nociceptive receptors, and central chemoreceptors. Nociceptive receptors are for the chest pain and not for the dyspnea. So answer is D. Next question. All of the following stimulate afferents in dyspnea reflex except anger, metabolic activity, altered breathing pattern, irritants, and alkalosis. So you can have a stimulation of dyspneic reflex by sheer anger, metabolic activity, altered breathing pattern, as well as irritants, and acidosis, not alkalosis. Next question. Alkalosis is a consequence of dyspnea. All of the following are causes of dyspnea except hepatopulmonary syndrome, methemoglobinemia, Cushing syndrome, paraneoplastic syndromes, and dextrocardia. And the answer is dextrocardia. Next, please. Most sensitive clinical finding to diagnose disease causing dyspnea is raised JVP in heart failure, history of smoking, which is like 40 pack years for the diagnosis of COPD, decreased bilateral breath sounds in suggestive of COPD, pleural rub in diagnosing pleural effusion, and history of atrial fibrillation in diagnosing heart failure. So the most sensitive clinical finding is raised GVP to pick up heart failure as the cause of dyspnea. Next, please. Most common tests to evaluate dyspnea initially include all of the following tests except labs with TSH and BNP, complete lung function tests, chest X-ray and HRCT, so imaging, CPAT, that is cardiopulmonary exercise testing, and EKG. So initial tests do not include CPAT. They include routine tests which have been mentioned here. So answer is D. Next question. Which test is least likely to be of help in investigating dyspnea? Echo, CPAT, CTPA, bronchoscopy, and sleep study. So bronchoscopy is one test which is least likely to be giving us etiological diagnosis of dyspnea. Next question. Which test is likely to be of help in investigation of dyspnea on lying down? So if somebody complains of dyspnea only on lying down, not on sitting, what test could be used for those patients? So respiratory muscle pressures, spirometry sitting and lying, lung volumes, diffusion capacity, and a CPAT. So spirometry done in sitting and lying down with a fall in FVC of more than 20% is suggestive of diaphragmatic palsy. And that is what is picked up for causes of dyspnea, which increases on, or rather only comes when the patient is lying down. Next question. So this is the last question. All are used to grade the dyspnea, the amount of dyspnea. So grading of dyspnea, you can use all these scales except one of them. MMRC, Bohr, CAT scale, CAT and Dalhousie scale, and ACT. And the answer is ACT, because ACT is asthma control test. It does not grade dyspnea. Rather, it only tells us about asthma control. All others are basically for the grading level of dyspnea. So I do not know how many of it were correct for you, but if you are not, then you should go back to the module and listen to the teachers, the mentors, and then attempt again so that you get 20 out of 20. So with this, I would like to close this session and welcome you for the next part of this, which is going to be in the month of May. And it is coming on the third Sunday again. And we will be talking about the two more symptoms in respiratory medicine, that is hemoptysis and chest pain. Our mentor will be same, Professor S.K. Jindal, and there will be case-based as it is like, which has been done today. So with that, I would like to say thank you for being there, and keep joining and keep learning and keep spreading this knowledge, and keep this program alive, even by coming and hitting it again and again and joining it. And this all is possible because of our knowledge partner, Glenmark, which has helped us to actually curate this program for postgraduates all across India. Thank you very much, and see you again next third Sunday of month May.